Good morning. That was an eye-opening keynote address, and it offered hope for the future, especially our children's. Thank you for joining us for Session 1, Program Innovations for the New Normal, Making Pandemic Adjustments Permanent for Families. We are looking forward to a great session. A few logistics notes as we begin. This session is being recorded, and the chat is being archived. Attendees are in view-only mode to keep things orderly. You cannot use your microphone. We encourage you to use the chat box throughout the session to engage with the group. You can post in the chat for any technical issues you experience, as well as any you would like to share with presenters. We will share these questions toward the end of the session. This session uses auto captioning. While these sessions will not be exact, we hope they can improve accessibility for all attendees. To activate these as a viewer, please look for an option on your toolbar that says Live Transcript and select either Subtitles or Full Transcript, which will appear in the sidebar. Your options may differ on a mobile device. A recording of this session will be made available on our YouTube channel. A quick note on professional development credits. If you are an early educator intending to claim professional development credit through South Carolina Endeavors, please complete the submission form we are about to share in the chat box before the end of the session. This is essential to having the information needed to process your credits. Remember that you must attend the session for its full 1-hour duration to receive credit. These sessions are also eligible for CME credits. Further information, including the link to complete your attestation form, will be sent in a follow-up email next week. For CME and all other professional development credits, ICS will be happy to provide verification of attendance. For that and other professional development credit inquiries, please contact John Young Schick Conklin, and that email address will be provided in the chat. If you have any questions about this process, please return to the Zoom lobby after this session where someone can assist you. We encourage you to use the hashtag NDM2022 when you post on social media. At this time, I am pleased to introduce Linda Breeze, ICS Senior Fellow, who will moderate today's session.
Thank you, Lisa, and welcome everyone. We're really in for a great treat today. We have a lot of experts in the field that will be sharing information about their own program innovations. We have today as our three speakers, Tanya Camunas, who is the Executive Director of A Child's Haven. We also have Dr. Ben Goodman, who is a research specialist at the Duke Center for Child and Family Policy. In addition, we have Sonya Ebeling, who is the manager of the South Carolina Telehealth Alliance at the Medical University of South Carolina Center. So it's my pleasure today to have Tanya start our discussion. Let's hold our questions till the end, and then we'll have an opportunity to all participate in some question answer time. Tanya.
Good morning, everyone. Thank you, Linda, and I'm really excited to be here with the other panelists to talk about A Child's Haven and what we are doing at A Child's Haven to bring us through COVID. And in a lot of ways, we learned a lot, and I'm excited to share that with everyone on the call. So I am going to share my screen, and I'm going to try to do this seamlessly, so bear with me. Sharing my screen here. Let's see, wrong screen, I apologize. Okay, so everyone should be seeing my screen now. All right, well, my name again is Tanya, and I am representing A Child's Haven today to talk a little bit about our program. I realize that there are some individuals who might not be from South Carolina on the call, And so I wanted to ensure that I just also cover a little bit about a Child Haven. So a Child Haven, we are in South Carolina. We are a therapeutic childcare center. We are one of two therapeutic childcare centers in South Carolina. And we have been around for 30 years. I have not been here for 30 years. I've been with the Child Haven for about 5 years. But the work and the mission has been going on for 30 years. And really what we do is provide necessary behavioral health services and childcare to children who need it. And the children that we're specifically talking about and that we serve are children who have suffered trauma and adversity due to abuse, neglect, limited resources. And so what we do is we work with those children, and those children are expelled and suspended from typical childcare centers. And that is one of the main issues that we help to address here in our community, is the problem of behavioral health and mental health in young children. And just from our keynote speaker, just doing such a wonderful job of putting it all in context in that we always have known that mental health is something that impacts our children, generations, and we are here in a Child Haven to not only acknowledge that, but to provide the necessary intensive services that are evidence-based, that will help heal children from that trauma, but work with the families specifically to help promote positive outcomes. So at the Child Haven, what we do, we provide 3 core services to all families who are enrolled for a Child Haven. Families are referred to us by pediatricians, by anyone who comes in contact with children who have developmental delays, and they think that would be a good fit to come to a Child Haven. So we receive referrals in many different ways. And again, we're trying to be as upstream as possible so that we can serve children before school starts from ages 0 through 6, so that when they are getting to the age when they're about to go into school, that they are best prepared holistically, academically, behaviorally, emotionally, and socially. And so we really take into account the entire child and ensuring that the treatment that we provide to them includes and is focused on the relationship between the child and the caregiver. Because as we know, science tells us that we have to be working with our caregivers in order for the mental health, that sustained positive mental health to continue. So we provide therapeutic childcare, which is at our center in Berea in South Carolina. We are in Greenville, and we are in a county called Berea. It is an underserved area where there is limited access to childcare. There's limited access to services that are meant to strengthen families. And so what we're trying to do is build up and provide and fill those gaps that exist. So we are able to serve up to 90 children at a time with our current building. Our board over the years has been really strategic in what they've been doing to get us where we are and where we want to be. The building that we're currently at is a large, beautiful building that was on a 4-acre campus that we have. And we've been here since 2014. And this building is designed specifically to provide behavioral health services to children in a therapeutic childcare setting. And so when you come here, it looks like a child care center, but what you will see happening is therapy. There's individual therapy happening between therapists and children. And the ratios with the children to providers are much smaller than you would see in a typical child care center, intentionally to provide that individual one-on-one time to that child within the classroom. And so we have providers who are providing the therapeutic childcare to those children every day of the week, free of charge to all families. Again, all the families who are eligible are families who are receiving Medicaid. And then second core service is individual therapy, which is that play therapy between the child and a therapist that happens on site in the rooms that we have provided. And then the third is family therapy, which is in the home or at our center, which is dedicated to the child and the caregiver, working on that relationship between the child and the caregiver. So those are our three core services that we continue to provide. As you can imagine, during COVID, running a therapeutic childcare in-person, highly in-person program became very difficult. And so it made us have to pivot hard, just like a lot of other nonprofits. And so what we are so happy to do is, first of all, we did have to shut down temporarily to close our doors to be safe for our staff and for our children when things were at its highest. And we really tried to make sure that during that time that our families still were provided with some kind of emotional and therapeutic support, because what we do know is that isolation is really, really difficult for our families. And so we were able to provide telehealth. We were able to get our providers trained in telehealth. And that was kind of like that one line that we're able to continue to have that support to our families and provide some instruction, some support in that capacity. But what we had to do is think about how would we reopen safely after COVID, knowing that not after, but through COVID, as we would have to manage, obviously, the impacts of it. And so part of what we were able to do during that time is really demonstrate our own resiliency as an organization and as a team, as a board. We really took that time to assess what we were doing and how we could use our current resources to open up safely and maybe even do more than we were doing before. And so one of the great things that we were able to do is become a full day program by securing additional funding for our program through ABC DSF. So we were able to become a full day program, which then allowed us to think about possible programs that we would be able to add. So that was one innovation. And then the second innovation that is really the one that we're really excited about is our outdoor learning projects that we have. Like I said before, we have 4 acres of land here at a Child's Haven. And part of our strategic plan and our strategy is to optimize our building and our grounds to really be conducive to providing the most effective therapeutic treatment to children and families. So during this time, we were introduced and engaged with a designer who specializes in creating and designing outdoor environments for children that would promote the health in physical health, nutrition, mental health, and also be able to provide our providers, our workforce that is growing, just the best state-of-the-art equipment that they would be able to provide the most effective therapy to our children. And so what was born from that is something called our therapeutic outdoor environments. And that is what you should be seeing on your screen coming up. It's hard to see, but on our website too, I would like to also mention, please go to our website. All of this is really well done by our team of talking about each individual outdoor environment that we are transforming from what it is, which was really untapped, and we would use it as just land, as a space for children to have. But what we are wanting to do is think about what does it look like when we can optimize those spaces, and knowing what we know around what nature itself can do for our mood. I know when I walk outside sometimes during lunchtime, just from meetings and being in walls and under fluorescent lights, going outside, going for a walk, what it can do for a mood. And for our children here, that's what we're focused on, is helping them cope and find strategies and heal and do all of those things. And so with our outdoor environment project, what we are wanting to do is utilize and optimize all those spaces, so when there's more outdoor time, because we are a full day program, that children and providers have these spaces that promote learning, promote discovery and social skills and so many different creative things that can happen. And the design specifically that we're really proud of is by John Fritz, who is trained and certified to do designs in this nature. So the Natural Learning Initiative is something that came out of something in North Carolina State University. And so he is certified in that. And since that is something in South Carolina, and I think in a lot of other states as well, there is a push for children to be outside, for people to be outside, especially with COVID. Maybe that's one of the things that came out is people are gardening more, people learn to grow their own vegetables, and people are going for walks and seeing the benefits of it and feeling it of it. And so children need that too. And we know that. And there's for optimal development for children, we just want to think about everything that a child needs, but especially for the children that we're serving and for the adversity that they chronically have in their homes and with their families. We need to be providing the optimal program to rehabilitate our children, heal our children, and heal our adults. And we just are really proud of being able to serve in this capacity. Our goal is to expand and to be replicated throughout South Carolina, and really, first of all, becoming the county that can demonstrate that when you have strong programs like ours that are specifically dedicated to preserving children and families together and working on relationships, and when you have safe environments and programs that are effective like ours, our children are healthier, our families are healthier, our communities are healthier, and that's just what we're all about. Lastly, this work that I'm talking about here, we had a groundbreaking for our phase one. This is a fully funded project for our phase one. These are our 5 TOEs. Again, we thought it was cute with TOEs, therapeutic outdoor environments with, you kind of can imagine cute toes in grass or outside. And that was kind of the idea of children getting outside. And so we have a committee that is formed now to think about future possibilities with the other acreage that we have on the other side of the fence, as we call it, around potential food gardens for our farm to table programs, fighting food insecurity. We are in a food desert in Berea. And so we've already started composting and thinking about how we can, as an organization and program, be responsible with our mission for serving the community and the people, but also our environment. And so we started composting and putting that within our program about how to be responsible with waste and how we can actually give back to the environment. And so there's a lot of learning and exciting innovations that are still in the works. And we have really great experts in the field of nutrition from Live Well Greenville, for example, from DSS and from ICS, and experts in the field of early childhood development that are really behind this project and helping us first design and be innovative in this space, but then hopefully be an example and a training site potentially for our community and other programs that are interested in outdoor learning. I feel like I'm probably going over my time, so I'm going to wrap this up and turn it back over to you, Linda. And I just wanted to encourage everyone to please go to our website. We have just launched a new one on our website too. All the things that I talked about are in our impact report. If you can see our impact report, we have a digital copy on our website. I encourage you to go to that and see the impact that we are making by numbers. And also this kind of shows all of the donors and our supporters in the community that are really that make this work possible. And so we would like to show what the funds go to which is towards our program. So I wanted to also just say that, please go there and contact us if you want to learn more. We're always trying to think about expansion, collaboration, ways that we can work with others to just create a better environment and future for children. So thank you.
Thank you so much, Tanya. That was exceptional. Now can we hear from Dr. Ben Goodman?
Hi, everybody. Thank you so much for being here. Exciting to talk about our work and with Family Connects and trying to figure out how to adapt a universal postpartum nurse home visiting program kind of on the fly during COVID-19. So you can go to the next slide, please. Just a little background to level set. Obviously, the COVID-19 pandemic forced, sorry, let me keep track of my time here, forced all home visiting models nationally, including Family Connects, to have to rapidly transition away from in-home service delivery to virtual means of continuing to support families. And collectively, we all saw virtual home visiting as really an essential way to continue to connect and support families, addressing their immediate needs and continuing to support connections back to community resources and services during really an unprecedented time in our collective history. However, although many models, including Family Connects, are evidence-based and McVie approved, the impact of this transition to virtual service delivery on program implementation was largely unknown. Next slide. So just a little background and context about the Family Connects model itself. So this is the original evidence-based model as it was designed. So it's basically engaging with families shortly after birth and then 3 to 5 contacts with families on average, typically between birth and 12 weeks postpartum. So it begins with an initial engagement with the family, introducing the program, and for families that are interested in participating, scheduling an integrated home visit, either right after birth or as soon after birth as possible. The integrated home visit itself is the core of the home visiting work. These home visits are conducted by public health registered nurses, and they are typically about an hour and a half in length, and they include comprehensive physical assessments for both the mother or birthing parent and the baby, education for all families about newborn care, topics that are common to all families with newborns, such as safe sleep or appropriate feeding practices, and then the core of the visit and of the work itself is the systematic assessment of family strengths and needs in 12 factors or domains that are empirically linked both to long-term child and family well-being generally, as well as risk for child maltreatment specifically. And then based on the results of that assessment, home visiting nurses can either provide brief intervention and support the families when needs are more minor, or when need is more significant, work collaboratively with that family to get them connected to community resources for longer term support. The follow-up visits can be made by nurses as clinically needed. That's typically either to conduct additional assessment if there are needs that require follow-up, or parts of the visit of the integrated home visit couldn't be completed during the first visit, or to provide additional brief intervention and support connections to the community. Next slide. So in thinking about how Family Connects adapted and responded to the onset of COVID, we took a two-pronged approach. So the first was what we called our modified virtual IHV, or integrated home visit. And essentially that approach, which was the approach that the majority of families received, included all of the core components of the original evidence-based protocol, with two minor adjustments. The first is that we introduced a standard call for all families at 1 week to try to catch families quickly and identify any immediate needs that the family may have and that might require nurse engagement prior to that 3-week home visit. And then in terms of the integrated home visit itself, that virtual connection still included all aspects of the original protocol, but the physical assessment piece was done virtually, obviously, because the nurse couldn't be in home. Acknowledging and recognizing that not all families may be interested in or maybe even able to participate in an hour or hour and a half long virtual session. We also introduced what we called a structured supportive call. So this was a lighter touch, more like 20 to 30 minute kind of engagement with families that followed the same structure in terms of initial engagement after birth, and then the 1 week call to assess immediate need during the first week postpartum. But then instead of the full integrated home visit, families completed more of a check-in call with the nurses, where the nurse would discuss with the family and ask about common challenges that are common to parents and families in the early postpartum period. So asking about postpartum depression, asking about food security, childcare, but it was a much briefer assessment and did not include actual rating of the 12 factors of the support matrix. Next slide. So to understand the impact of this change to virtual service delivery on Family Connect's implementation, what we did was we reviewed data from 5 of our certified sites nationally that had been implementing the model for at least 3 years. And we chose to review the data from well-established sites, primarily to increase our confidence that any changes we saw in implementation were due to a combination of COVID and this transition to virtual delivery, rather than other external factors related to, for example, a new site just getting up to speed. So two primary sources of data we reviewed and I'll show today. The first is program activity data between January 19 and November of 2020. So it involves a review of almost 10,000 case records, looking at number of scheduled visits, number of completed visits, as well as nurse education and family referrals. And then for a subset of families to try to assess immediate, very short-term impact of participation, we had a subset of families complete a brief questionnaire examining how participation in Family Connects affected feelings of isolation and willingness to seek routine medical care during COVID. Next slide. So table, really the numbers in the column or in the far right are the takeaway here. So we compared these are comparisons of data, same month, same site, for the period of March to November of 19 to March to November of 2020. So the period just before COVID, and then the period once the pandemic began and we transitioned to virtual services. So overall, and interestingly, scheduling rates were up slightly during the COVID period. Not dramatically, obviously, but actually saw a slight increase in number of families interested in participating. And the nurse rates of education and supportive guidance were also virtually unchanged. We did see a small drop in the ability to complete integrated home visits with families that is scheduled, and also saw a slight drop off in rates of referrals back to the community for longer term support. And we'll touch a bit in the discussion on why that might be the case. Next slide. So in looking at family response to the experience of virtual family connects, 89% of families that took that, of the subset of families that took the COVID survey, 89% reported that the frequency of contacts was just the right number for them. That was about 4 to 5 contacts on average for families. 65% of families reported decreases in feelings of isolation after participating in Family Connects, and 62% reported some level of decrease in concerns about seeking routine medical care, with the rest reporting that their concerns remained unchanged. Next slide. So overall, we do feel like this is some promising preliminary evidence that Family Connects can be successfully implemented virtually, but we did note that there were some challenges. So the scheduling and education rates were unchanged, as I mentioned, but we did see a decrease by about 10% in rates of visit completion and rates of referrals back to the community. We were very pleased to see that the majority of families, or almost all families, were satisfied with the number of intervention contacts, and that participation seemed to have a positive impact on reducing feelings of isolation and concerns about routine medical care. Next slide. So circling back to why we might have seen some of those decreases in connections and completion rates, in talking to site staff, the nurses noted, particularly as we got further into the pandemic, families began to experience Zoom fatigue, just burnout from everything suddenly being online or virtual in some way, and also some challenges in conducting some aspects of the visit virtually. So it was more difficult to assess physical need. It can be more difficult to assess domestic violence virtually during our initial design of the program. So based on some of that feedback, we are continuing to refine this approach and introduce some new modifications. The first being what we call a hybrid model, or allowing a limited opportunity for the nurse to do in-person assessment based on family identified need, where something like breastfeeding support or a need to conduct blood pressure assessment on the mother, where really having the nurse in the home is the best way to address that. And we're also introducing additional screeners for items that might typically be assessed by observation to help with some of those nurse-reported challenges in assessing need. And then finally, actually next week, we are launching a new formal study, 2 counties in North Carolina, to evaluate implementation quality and impact of the hybrid delivery model of Family Connects. So thank you all very much for your time, and I look forward to talking with you all more during the discussion.
Thank you so much, Dr. Goodman. Now we will hear from Sonya.
Hello, good morning still. Great to be here. Really awesome to be included on this great panel with these innovative programs. I've already learned so much from my fellow panelists. I am the manager of the South Carolina Telehealth Alliance, which is administered and headquartered out of the MUSC Center for Telehealth here in Charleston, South Carolina. Excuse me, I think, I'll start with just maybe a little bit overview of what the SCTA is in case folks aren't familiar. A summary, if I can, of course, of the experience of telehealth during the pandemic, and then kind of what at least the SCTA and others are doing to make some of these temporary adjustments potentially, permanent for families. So the SCTA was founded in 2014 through funding from the South Carolina State Legislature. Like I said, we're administered out of the MUSC Center for Telehealth, and we are a statewide collaboration of many organizations working together to expand telehealth in the state. We do this through a series of contractual relationships. So we receive, like I said, state funding on an annual basis. And some of that money, of course, stays with the MUSC Center for Telehealth to kind of sustain and grow the operations of the telehealth programs from MUSC. But the bulk of that funding actually goes out to other health systems, community partners, to help with this mission of expanding telehealth. We're guided by an advisory council, which has, representation from our various funded partners, including the Department of Mental Health in South Carolina, Prisma Health, McLeod Health. South Carolina Medicaid is on our advisory council, Hospital Association, and more. And that council is co-chaired by Dr. Jimmy McElligott at the MUSC Center for Telehealth, as well as Kathy Schwarting, who is the CEO of Palmetto Care Connections, which is an amazing organization that is focused on telehealth specifically for rural and underserved areas, specifically through the lens of broadband access. So really great representation there. And then we all kind of stay organized. Obviously it's a innovative group because although we are maybe competitors in other areas in terms of healthcare systems, through this funding and the SCTA, we work collaboratively through a statewide strategic plan to advance our goals and expand telehealth in the state. Pandemic shifts. Well, telehealth, I started working in telehealth in 2019, in August, and then of course, March 2020 happened. So it's been a whirlwind, but telehealth, South Carolina was in a okay place in terms of telehealth infrastructure. Luckily, having a pretty mature and extensive telehealth network in place. More, I would say, for kind of the larger SCTA partners, those large health systems that I mentioned, but also mid-sized partners, as well as some federally qualified health centers and community providers. So there was a good amount of telehealth happening in the state pre-pandemic. The majority of it was happening site to site. That's say that a patient goes to a clinic and needs a specialty consult and is able to get that specialty consult via telehealth with a provider maybe in Charleston or Columbia or Greenville, or hospitals supporting other hospitals. We've had a very robust telestroke program in place and tele-ICU programs in place. So it's really kind of this site-based telehealth. With the pandemic, of course, as everyone goes without saying, is largely aware, we really saw that shift to a focus on direct to patient telehealth, specifically into patients' homes. And that was that was a big pivot. It was great that we had a lot of good infrastructure in place, but it was still a large pivot. Many of the larger health systems, or sort of I will say like the more mature telehealth infrastructure organizations, quickly onboarded like thousands of their primary care and ambulatory providers to various telehealth platforms to be able to extend that service into patients' homes. And obviously, of course, we still had a group of physicians and other healthcare practitioners in the state who maybe had never done telehealth before and had to pivot quickly, make programs and implement them quickly, and needed support. So one way that we did that was in the South Carolina Telehealth Alliance expanded its clinic level instance of Doxy.me across the state. Doxy.me is a free platform, but there is a slightly more kind of advanced functionality in the clinic level instance. We were able to extend that for providers across the state. I believe we launched that in May of 2020. And since then, we've had about 1,600 accounts requested and about 90,000 visits in both 2020 and 2021. So although this was supposed to meant to be initially kind of a public health emergency initiative, because of the large uptick and the value that a lot of the providers, especially in the rural communities, are seeing, we intend to continue this as a resource for providers. And I'll say also, just to share a few numbers, In 2019, the SCTA annual report, where I said there was telehealth going on and it was in fact growing, we had about 435,000 telehealth interactions take place. In our 2020 annual report, we calculated over 2 million telehealth interactions taking place in South Carolina, and 1.2 million of those were those ambulatory telehealth visits, in which I described going directly to patients and directly into their homes. So huge uptick there. A big piece of this and what made a lot of this possible was temporary changes in the payment and reimbursement landscape for telehealth coverage and payment. So in March of 20, very quickly after the pandemic started, CMS quickly announced telehealth coverage and payment flexibilities. And then South Carolina Medicaid and other private payers also followed suit, right? This was with the public health emergency declaration. There were many flexibilities added. Some of the big ones are removing something called the originating site restriction, which is that piece that does allow patients to receive telehealth into their homes and allows those visits to be billed. So that allowed, providers and patients to continue those healthcare visits, and also contributed to providers being able to still be reimbursed for those types of visits. Expanded services that could be covered via telehealth, and also expanded provider types. So whereas before maybe only certain provider types could be reimbursed, a lot of the flexibilities allowed to quickly turn on coverage and payment for things like master's prepared counselors, PT, OT, ST, and other allied health professionals. And so they then were able to bill for those. Now, I'll note that, and then I'll also say a big piece was also expanded behavioral health visit types, new patient visits, and other telemedication assisted treatment, kind of just a breadth of codes that could now be reimbursed. So that really helped. Suddenly we had a very favorable reimbursement landscape for telehealth, which allowed the impact and the programs to grow even more. I'll say the flexibilities from CMS and South Carolina Medicaid, the vast majority of them are contingent on the public health emergency. And folks probably know we are still in the public health emergency. It was renewed in January. And so those flexibilities do remain in place. However, there's planning and conversation and whatnot about what are we going to do after, right? After the public health emergency goes away. Because folks generally, both across the board from private payers to Medicaid and CMS, know that we can't go back necessarily. And so as the SCTA, one thing kind of going into now what we're working on to help make sure that some of these things remain permanent is we have been engaged in conversations with Medicaid and legislators and other kind of champions in South Carolina to make recommendations about what types of services and visits and providers should be that we recommend from with evidence that have been for whom telehealth has been advantageous and what sort of populations. And so those considerations, those recommendations have been taken to heart, I think, by payers, and we are in a pretty optimistic place of alignment in a lot of these areas, mainly in that, like I mentioned, the originating site restriction piece and providing telehealth into the home that in South Carolina Medicaid will likely stick around. So there's a few areas of alignment that we're really excited about. And then all the while, we are also exploring solidifying and formalizing the telehealth reimbursement landscape in the state a little more formally through potential, legislative steps. And so that's another thing that is ongoing, and those conversations are happening. It's tricky, but it's exciting. And like we said, there's a lot of great momentum and alignment. And so hoping to continue those conversations and get something more formal. So that's a little bit about kind of where we are, what we've been doing. I guess I should I'll pause. We have a number of other different types of pivots in terms of how we had to quickly, train and educate folks, and broadband advocacy is a huge part of this as well. And I could go on and on, but I think I'll pause here and maybe allow the discussion to start if folks have questions.
There have been some questions in the chat box specifically for individuals. But before, if Sonya, you can talk just briefly about telehealth and how it's working in school-based health centers and any of the challenges in relationship to, billing private insurance, trying to get more funding for that aspect, especially with the mental health crisis of young children. If you can talk briefly about that, that'd be great. Then we'll start our questions.
Sure. So South Carolina has a robust school-based telehealth network, right? MUSC has a large school-based telehealth program, Prisma Health, McLeod Health, a number of our federally qualified health centers are also running school-based telehealth. We actually are in the process of doing our annual report numbers for 2021 right now. And I think we had about, I'll wait to finalize the numbers, but I think it was about 30 counties in which there are schools with telehealth partnerships in the state. In terms of billing and reimbursement there, I know that those are covered services from Medicaid. I don't have the details of whether the various private insurers in the state, but if they're, that's certainly something that comes up. I would love to have had our school-based telehealth manager on here to be able to really speak more eloquently to that. But the programs, I know that in terms of COVID, there was quite a decrease in volumes during COVID. Obviously, schools closed, but there were some pivots in that program as well that were pretty innovative. Like I know at the MUSC school-based telehealth program, they were able to transition those school-based telehealth visits into the patient's home using, iPads or a video-based platform. The billing and reimbursement conversation, I wish I had a little bit better of insight on that for you, and I'm sorry, but I know that that's a big priority for South Carolina Medicaid and our Medicaid director, Director Robbie Kerr. So I would expect more conversations and more kind of innovation in that area in the coming months.
Great, thank you so much. Ben, there was a question concerning Family Connects and whether or not Family Connects will be able to retain and continue to fund the innovations going forward.
Yeah, I'm happy to talk about that. I think sort of a two-part answer. The first is in the short term, we are retaining flexibility for all of our sites based on local conditions on the ground. And that really is site specific as to whether home visiting is even allowed at the organization in which the program is locally based. So certainly while we're still in the pandemic and likely even into epidemic state, we will allow sites to retain that flexibility to use telehealth as needed. Longer term, if we can imagine a post-COVID world, part of the goal of starting the new evaluation in March is we would like for telehealth and for flexible or virtual service delivery to be an option. We think it's, I don't think it's really a one-to-one substitute for in-home visiting, but I do think that offering flexibility and choice to the family and to the home visiting nurse is just a really helpful tool towards the goal of maximizing the number of families that you're able to engage with, as well as offering more flexible tools, particularly for follow-up touch points with families after that initial integrated home visit. But before we sort of say, Family Connects, the virtual or a hybrid model is now part of our evidence-based protocol. We need an evidence base behind it. And that is something that we believe is important, but also hope to see more broadly in the field of home visiting. Is certainly when COVID hit, nobody was, everybody just had to pivot and do the best they can. But hoping that more and more programs, including Family Connects, will actually take that extra step of doing formal impact evaluation. And then for families that might not be interested in home visiting services, for sites like rural communities or communities where there may be real nursing shortages, having virtual as a delivery option, at least for some families, I think would be tremendously helpful and a real valuable addition.
Great, thank you so much. Tanya, another question for you. You discussed in your presentation that a Child's Haven had to actually close. And what are your feelings about any changes you saw in the children once they returned, and how you as a staff responded to those changes? What kind of accommodations did you have to make as those children came back for the first time after Child's Haven was closed?
Sure. Yeah, great question. We did see heightened behaviors as far as concerning behaviors. We did see some regression that happened in the treatment just because it was completely stopped. I mean, part of what makes us therapeutic is that relationship between the therapist and the child, and the therapist and the caregiver, and the intensity and the dosage of our treatment is pretty intense. We would be at kind of near the top when it comes to the intensity level. Next would probably be inpatient for some of our children, especially our older children. But we did see a regression what in behaviors and then in treatment, and also in the adults as well. I mean, the stress level just across the board was just even heightened, even more so. And for families that we're serving, I mean, stress, adverse childhood experiences, that multi-generational, all of those are already very high. And so having, with COVID just added into it, as you can imagine, just it's just a compounding effect. And of course, that's why we pivoted really quickly with the telehealth to as the kind of the first thing that we did to make sure that they knew that we were still here, that we were, that their therapists were still here, that they had at least that emotional support. We were able to help financially in some ways with food and different items. Our community helped us do that, and we had some different programs. But just to answer the question, we did see regression, and we continue to see heightened behaviors right now with our children as we continue to grow. So hope that answers the question.
It does. Thank you very much.
And I did want to make sure that I answered the other part about accommodations. One thing that we wanted to do is we kept our COVID policies and procedures that we follow are still, we are very conservative, meaning that we want to make sure that we are using all of the protocols still, with temperature checks and masking and all of that, to protect our vulnerable children, who, again, from a health standpoint, I mean, these are children too who are vulnerable to disease and anything and other things. So, but we also tried to, with our programming, because of children, we know to understand the trauma piece. Our clinicians and team were so great about coming up with creative ways to still be engaging for them, for the children to be able to see, to not be scared by the sterile look of a mask and a cap, and really try to welcome and not, because they're already coming in with anxiety and high anxiety and concerns. So we really did a very step-by-step approach, and I really owe it to our providers who are just so caring and could understand from their perspective how it would be.
Great. I don't see any additional questions in the chat box. and we're right at time. So I just wanted to take the opportunity to thank all of our speakers today. All of you did an exceptional job, and we look forward to our next session that will occur shortly. Thank you so much.
Yes,
Thank
and I
you.
want to say thanks for joining us again. And if you're claiming South Carolina Endeavors credit, please make sure you completed the Google form at the top of the chat box. And we will be providing a recording of this session to you in email, and that will come early next week. Thank you to all of our presenters and to all of you for the work that you do. Have a great day.